Mental health problems such as anxiety and depression are common among people living with COPD and have a substantial impact on quality of life. These conditions can worsen breathlessness, reduce adherence to treatment, increase the risk of hospitalizations, and lower overall survival. Despite this, they often remain underdiagnosed and undertreated. Studies show that 30 to 80% of people with COPD experience depression, and between 10 to 50% experience anxiety. The likelihood increases with advancing age and disease severity. Importantly, quitting smoking does not worsen anxiety or depression. In fact, it has been shown to improve mood and overall well-being. However, symptoms of nicotine withdrawal can sometimes mimic anxiety, making assessment more complex. It is therefore essential to routinely assess anxiety and mood at each appointment to distinguish between psychological distress and withdrawal effects, ensuring that support is tailored appropriately. When caring for people with COPD, anticipate that depression or anxiety may be present and look for signs. Utilize OARS skills, which include open questions, affirmations, reflection, and summary, to establish and maintain rapport and foster trust through both verbal and non-verbal communication. Pay close attention to non-verbal cues, such as long pauses, flat tone, or lack of eye contact, which may signal distress or disengagement. Validated assessment tools can help identify mental health concerns early. The Patient Health Questionnaire 4, PHQ-4, is a brief screening tool that combines the GAD-2 for anxiety and PHQ-2 for depression. A score above 3 on either subscale suggests the need for a more detailed assessment using the PHQ-9 for depression or the GAD-7 for anxiety. These tools are quick, easy to administer, available in many languages, and well suited for primary care use. Non-pharmacological interventions are foundational to managing mental health in COPD. Cognitive behavioral therapy, or CBT, effectively reduces symptoms of depression and anxiety, especially when integrated into pulmonary rehabilitation or self-management programs. Other helpful interventions include mindfulness, relaxation techniques, singing therapy, acupuncture, and positive psychology interventions that strengthen self-efficacy. Encouraging time in nature, group activities, and social participation can also support both mental and physical well-being. Pharmacological management may also play a role. Treating breathlessness effectively with bronchodilator therapy and addressing tobacco dependence through pharmacotherapy and counseling can reduce psychological distress. For depression, selective serotonin reuptake inhibitors, SSRIs, are the preferred option. If SSRIs are unavailable, tricyclic antidepressants, TCAs, may be considered with caution, but they are not recommended in severe COPD because of the risk of respiratory center depression and respiratory failure. For anxiety, SSRIs may help, but the evidence is limited. Benzodiazepines are not effective for breathlessness and should only be used short-term at the lowest effective dose for acute distress. Remember that smokers metabolize antidepressants more rapidly, so dose adjustments may be required after quitting. Refer people with COPD to mental health services where available, especially if they prefer psychological care or when anxiety or depression does not improve despite intervention. Immediate referral is essential for anyone experiencing psychosis or suicidal thoughts. By addressing both mind and body, we help people with COPD not only breathe better, but also live better. Now, time to solve a short quiz to reinforce your learning. A set of selected IPCRG resources will be available for you at the end of this breath.